Good morning. I just wanted to recognize Dawn Coleman, one of our counselors in the APDVS who's currently serving the country in Afghanistan. I know she would be here if she could, so get home safe, Dawn. So we're going to talk about the fundamentals of vascular surgery twice in this meeting, once today and once tomorrow. So for the first part, we're going to talk more about the science behind it, the proof that it's helpful, and how it actually works. And then tomorrow we're going to go into the nitty gritty and what's actually required for you to begin the program at your own home institutions. So this has been a work of many. This is the core team here, which has been doing this since 2007. But probably, at least a third of you on this call have helped in some way, whether it's sending your trainees to us or by serving as assessors for the program. So really, this is kind of a group effort by the whole APDVS. There's no money. This is good and bad, but we don't take funding for anything except for the products that we use in the program. So it always bothered me that Europe was so far ahead of us as far as simulation and vascular surgery. And so I went over there early on to see how they administered their exam. And I thought it was interesting, but then I thought there was a lot of things that they did in Europe that wouldn't really correlate to the US. And the one thing I came away with is if we do an end of training exam, what do you do with the person who fails? Like, what recourse do you have? Do you send them back for more training? Do you set them loose on the world and tell them to come back and practice? Who are they going to be practicing on? So it didn't seem like a practical idea for us to institute in the US. But like I said, it's been going on in Europe for over 15 years, but they have a different kind of paradigm there where the trainings don't always match up from country to country. So they're trying to standardize their training. Here in the US, I don't think we have a problem of people graduating who are technically deficient. I think we have a different problem, which I'm going to hopefully show you today. So the first model we came up with, it has a lot of face validity. It looks like what we do in the OR. And this is a simple end to side model. So it's two 8mm PTFE grafts that you simply do an end to side anastomosis on. And the trainee is judged on how quickly they do it, how well they do it, how evenly spaced, how everted the edges are, how well they use their assistant and things like that. So the first model is relatively simple, but then we sat down 9 years ago and tried to figure out, well, how would the other models look? And so we used FLS as kind of a jumping board, and FLS tried to break down all of the technical skills into individual steps and then take that out of the operating room and break it down into something even further to a single skill. But as we did this with vascular surgery, we came to the realization that some surgery is like baseball, where it can be easily statistically broken down. Throw the ball, hit the ball, catch the ball. But a lot of vascular surgery is more like basketball. It's a confluence of movements that if you kind of isolate them too much, it stops really rendering any benefit to practicing. So we kept some of these skills fairly intact from what you would see in the OR. So the second model is the patch, and this is a patch angioplasty. And the trainee is given a 10mm PTFE tube, and they're asked to take scissors and bisect each of those hash marks, and they get a patch out of it, and then they sew the patch back onto the tube. So this one's a little bit more difficult as far as spatial awareness. And you can see the trainee can make a lot of mistakes with this. So they fail to evert the edges. They fail to space it correctly. They're also judged on their knot tying. And this is the one where if you give it to a novice, they really are not able to do it at all. So this is probably one of our best differentiator skills that we have. And then the final model is the clock face. You're given a sheet of PTFE and with this pattern stamped on it. And we call it a clock because it has 12 spokes. And basically, we want them to start at the 6 o'clock position and work their way around the clock with an SH needle. So originally, we started with something more like an aortic anastomosis, but we learned that it wasn't really the anastomosis that we wanted to test. It was their ability to manipulate an SH needle, especially with different angles, and make sure that they didn't damage the tissue as they would with kind of a complex aortic repair. So the clock face model, in reality, this was the early prototype, and you can see this large SH needle. And they want to go from the inner circle to the outer circle on each hash mark. So it tests their ability to kind of angle that needle and get a precise bite without damaging the tissue underneath. Here is what it might look like completed. we found that the initial model was kind of a poor discriminator, so we added a little bit of challenge to it by putting it in a tube. And this can be graded by accuracy, by errors, and also by the time it takes to do it. And as I said, we've made some adjustments. So this patch, the clock face now sits inside this tube. So the models were all validated in 2013. And after we validated the models, we set out to test the trainees. So you can test people. You've probably seen us do this at VAM and other places, but really to get an accurate test, you need a good testing center. So the data I'm showing you today was only done in our lab at LSU, or Mighty at Houston Methodist, or at the USF CAMELS simulation center. So when we do it, we have a standardized way of doing it. The trainees are paired up. One will perform the skill while the other acts as a passive assistant. And we still kind of grade these by actually watching them complete the steps. There are some ways to automate this, so I'll discuss towards the end, but basically we watch them do each skill. And we grade them, and then these are collected and kind of blinded and looked at afterwards, and they get a total grade. So for our testing of the residents, we used 11 assessors who had all been previously validated. You get a global rating score, which is kind of breaks down these things in different aspects like time and motion, respect for tissue, procedural flow, and then also a global summary, which is just a pass-fail. So 0 through 4, 3 is pass, 4 is expert, and 1 or 2 would be a fail. So we tested in these conditions 313 trainees, and you can see we tested people from basically every representative year in vascular training, including medical students who acted as the novice group. The consistency was good, which means that as a participant performed on one model, they generally performed on another, and you like to see that as a validation of your model. So here's how someone did on the patch, correlated fairly well to how they did on the ENTA side. And then these scores also correlated well with experience, whether that experience was measured in months spent on vascular surgery or as PGY year. You can see a good correlation of score with experience. And just looking at it a different way, here's experience in terms of cases done, in terms of months done, even in terms of the trainee's own self-reported confidence, it correlates well with their score. So can this discern junior from senior? And the answer is yes. Every single model independently can discern a junior from senior with good statistical accuracy. So here is the crux of it. And if you look, this is an individual skill, and you look at the large error bar. So 0 would be medical students, then 1, 2, 3, 4, 5 are the integrated, and 6 and 7 are the fellows. And you see the large error bars, especially early in the integrated training. And what that means is that there's obviously wide variability in how people do. But people in their first or second year can absolutely pass this exam. It's just most of them don't. And again, patch angioplasty, same thing. Even a medical student is capable of passing this, but obviously most don't. Each skill individually shows the same thing. So then we got to this point. So this is a completion of the whole exam with an overall passing score. And you can see that a PGY3 integrated resident only has about a 40% chance of passing it. And this is a basic fundamental vascular skill exam. And so what we're trying to do with the models is move this learning curve well over to the left. That way, when a 1 or 2 resident gets to the OR, they already have a pretty good grasp on how to suture. And so we can teach them what's hard about vascular surgery, which is actually vessel dissection and exposure. So this model has face validity. We've tested it far, far more than FLS ever was before it was implemented. General surgery already has a skills requirement, so this would be the first for vascular surgery. We have no financial conflicts. Nobody stands to gain any money out of this, certainly not us. APDVS, and actually the VSB also supports this now going forward, and we're going to talk more about what that means tomorrow. Like I said, I don't like the Europe model for us. I think that I don't know what we would do with those people who fail that, and I don't think that's a huge need. I do think we have a need of getting these skills into our trainees' hands much earlier on in the residencies and fellowships. And again, I'm a big opponent of putting any new burden on any of you without some kind of demonstrated deficiency. And I think that deficiency we've demonstrated is that the PGY 1, 2s, and 3s and the early fellows don't pass a basic skills exam with any kind of regular fluency. And we want to move that earlier into their training. So there's a endo model, and I'll talk a bit more about that tomorrow as well. And we do have a pilot program where actually most of the hurdles we've seen are legal. And so we're still ironing some of that out, but we'd like a national rollout sometime in the next academic year. We are working with engineers at Rice and Clemson and even Europe to try to automate some of these things. And some of their findings are pretty interesting. If you look at the top there, you see what an attending might do with the SH needle and the nice kind of fine track it would take, whereas a resident might have kind of more jittery motion with the needles. They try to find their way through it. So we're working on some of these to kind of automate so we don't have to actually watch each trainee do the skills. Happy to take any questions when we get to the panel. Thank you.